Okay, so the next video is on demyelinating disorders of CNS, part 4, in which we will study about the diagnosis and management of multiple sclerosis. We had already covered briefly about the topic multiple sclerosis. Now we will just have a brief repetition of it again over here. Okay, now what had we studied earlier? We studied that what were demyelinating disorders. In that video, we studied about the demyelinating disorders. Demyelinating disorders of the central nervous system, they presented with the multiple episodes affecting different locations of the CNS. Okay, demyelinating disorders of the central nervous system, they presented with multiple episodes. Okay, multiple episodes which affected the different locations of the CNS. Demyelinating disorders. Okay, they affect the CNS and they present with the multiple episodes. There are multiple episodes which affect the different locations of the CNS. And what are the sites of demyelination? In the sites of demyelination, the most commonly affected is the periventricular region. Okay, the periventricular region is the most affected site. Periventricular means around the area around the ventricles. Okay, for example, this is the upper view of the brain. This is the ventricle. This is the periventricular area. In multiple sclerosis, periventricular area is the most commonly affected. Then is the spinal cord, which is most commonly affected. Next to the periventricular region in the brain, and in spinal cord, sensory tracts are more commonly affected than the motor tracts. Then we have the optic nerve in the eye, then the cerebellum, the brainstem. First of all, the periventricular region, then the spinal cord, then the optic nerve in the eye, then the cerebellum in the brain, then the brainstem. Okay, cerebellum and brainstem are located together. At last, it is an autoimmune disorder in which both cell-mediated immunity and humoral immunity is present. Okay, and anti-MBP antibody is the most common cause of the development of humoral immunity. Okay, these were the sites of demyelination. Okay, and the cause is both cell-mediated and humoral, and in humoral we have anti-MBP antibodies. Now after that, after the sites of demyelination, we have epidemiology of multiple sclerosis. Okay, in epidemiology of multiple sclerosis, the age affected is 20 to 40 years. Females are more affected than males. Ratio is 3:1, and in countries there is increased incidence in countries away from the equator. Then now we study the sites of demyelination and the epidemiology, age, gender, and geography. Now the countries, which are the countries which are away from the equator? They are the North America and the Europe. After that, first of all, we studied what are demyelinating disorders. Then we studied the site of demyelination in multiple sclerosis, epidemiology, who are affected by this demyelination. Now what are the causes? Etiology, and risk factors in this case. Okay, first of all, the most common cause is EBV infection at young age. Then we have hypovitaminosis D. Okay, first of all, EBV infection at a young age. Then hypovitaminosis D, less vitamin D. Smoking can also be a cause. Adolescence, obesity. Okay, in genetics we have HLA-DRP1 gene. Okay, it is also associated. Now, how to remember the etiology of multiple sclerosis? So we can see that 20 years is around the age of adolescence, in which adolescents are mostly they come in contact with smoking. Okay, they think that it is cool to them smoking, and smoking can also lead to obesity, we can say. Okay, and vitamin D deficiency is also common, and at a young age EBV infections are also common. Now EBV infection is HLA-DRP1. Okay, as it is in genetic. Okay, after that we studied till now the sites of demyelination. After that site of demyelination, the epidemiology, the etiology, and then the clinical presentation. In clinical presentation, okay, it depends on the site of demyelination. It can be spinal cord. Okay, we all know the sites of demyelination. The most common presentation, it is sensory or long tract symptoms. As the most common presentation, loss of sensation of loss of sensations in dorsal column. Okay, sensations. After that, paresthesia. Then we have pain. Okay, second most common is optic neuritis in this case, which presents in 25% of the patients, which is unilateral and retrovulvar. In multiple sclerosis, the optic neuritis is on one side and it is retrovulvar. Involvement is segmental and affects around less than 50% of the optic nerve length. We had already studied it in the difference. The patient presents as monoocular painful vision loss. Okay, there is monoocular painful vision loss. Monocular painful vision loss in optic neuritis, and the patients with demyelination in the brainstem, they present with isolated brainstem syndrome. Okay, in case brainstem is involved, then the patient has isolated brainstem syndrome. Okay, where ascending and descending tracts, they are not affected, only the cranial nerve nuclei are affected. Okay, after that, the demyelination in cerebellum, it can result in cerebellar syndrome. Cerebellar syndrome is also common, in which ataxia is seen, nystagmus is seen, and most commonly dysdiadochokinesia is seen. Demyelination affects the motor pathway. Patient will present with weakness and spasticity. Weakness/spasticity of the affected part. Okay. Now, what are the related ancillary symptoms in case of multiple sclerosis? Ancillary means secondary symptoms. They are Lermiter's sign. Now what is Lemaitre sign? It is a shock-like sensation on the spine on forceful flexion of the neck. It occurs due to demyelination of the sensory tract. Simple. Lemaitre sign. And Utop's phenomena. Now what is Utop's phenomena? It is related to heat sensitivity. Okay. Of the symptoms of multiple sclerosis, that is whenever the body temperature it increases, there will be development of a conduction block worsening the system symptoms. Okay. Then we have the Pulfric's phenomena. Pulfric's phenomena. Just repeating the Utop's phenomena. It is heat sensitivity is the symptoms of multiple sclerosis. That is whenever the body temperature increases, there will be development of conduction block worsening the system symptoms. Okay. Pulfric's phenomena. When a pendulum is demonstrated to a patient in 2 dimensions, the patient starts seeing 3 dimensions. Okay. And MS hug. It is a tight band-like sensation. Just repeating the multiple sclerosis. That we studied demyelinating disorders. What are they? They are the disorders which affect the central nervous system of the body, and there are multiple episodes affecting the different locations of the CNS. Now, what are the sites of demyelination? First of all, the most common site is periventricular regions. Okay. Then the second most common site is spinal cord. Optic nerve can also be affected. The cerebellum, brainstem, they are also affected, and it is usually autoimmune. It is an autoimmune disorder in which both cell-mediated immunity and humoral immunity is seen due to anti-MBP antibodies. Now, after knowing the sites of demyelination and epidemiology, 20 to 40 years of age group is affected. Females are more affected with the ratio 3:1, and the people who are affected are away from the equator. Example in like North America and Europe. What is etiology and risk factors? After the sites of demyelination, okay, epidemiology of multiple sclerosis and etiology and risk factors. Sites of demyelination, epidemiology of multiple sclerosis. Okay. Etiology. Then now we study the sites of demyelination, then we study the epidemiology. Who are affected? Now what is the cause of this effect? First of all, adolescents, obesity, smoking, and then hypovitaminosis, EBV and HLA-DRB1. What is the clinical presentation? It is based on this site. There is sensory or long tract symptoms such as loss of sensation due to the dorsal column involvement, paresthesia, pain. There can be cerebral syndrome, which can show symptoms like ataxia, nystagmus, dyskinesia, isolated brainstem syndrome can be there. Optic neuritis, which is monocular painful vision loss. Okay, and less than 50% of the optic nerve is involved, which is unilateral and retrobulbar. And in ancillary symptoms, we have Lemaitre sign, in which last was left. Demyelination of the motor pathway leads to weakness and spasticity. And in ancillary symptoms, we have the Lemaitre sign. In Lemaitre sign, there is shock-like sensation on the spine on a certain flexion, on forceful flexion of the neck. It occurs due to demyelination of the sensory tract. Utop's phenomenon. It is heat sensitivity of the symptoms of multiple sclerosis. That is whenever the body temperature increases, there will be the development of conduction block worsening the symptoms. Pulfric's phenomenon. When a pendulum is demonstrated to a patient in 2 dimensions, the patient starts seeing 3 dimensions. MS hug, tight band-like sensation. Lemaitre sign, Utop's phenomena, Pulfric's phenomena, and then MS hug. That's all that we have studied till now in the previous videos. Okay. Now after this, coming to the management of diagnosis. First of all, the diagnosis. Now what is in the diagnosis? First of all, we have the MRI of the brain. In MRI of the brain, it is the imaging modality of choice. Okay. There are 2 types of lesions basically. First of all, we will talk about the T1W. Now what is T1W? It is wait a second. What is T1W? These are chronic demyelinating lesions, which are the hypointense lesions, which is known as the black hole sign. Okay, in the MRI of the brain, the imaging modality of choice. MRI of the brain is the imaging modality of the choice, and T1W is the chronic demyelinating lesions. And there is hypointense lesions in the brain which lead to black hole sign. Now coming to the image of the black hole sign, this is a black hole sign. Okay, this is a black hole sign. As there is chronic demyelination around the periventricular regions, these appear as hypointense lesions. Now after this, number 3, we have T2 flare. Now what is T2 flare? These are acute and chronic lesions which appear as the hyperintense lesions. Okay, T2 flare. These are acute and chronic lesions. They appear as hyperintense lesions. Okay, lesions. Now we had already studied this T2 flare. Now what are these hyperintense lesions on the MRI of the brain? They are arranged perpendicular to the line of ventricle, and they are known as the Dawson's fingers. this is an image of the Dawson's fingers. Okay. Now in the MRI of the brain, in the diagnosis of MS, imaging, what it is, the MRI of the brain is the imaging modality of choice, and T1W lesions, they are the chronic demyelinating lesions which appear as hypointense lesions, and this is the black hole sign, and black holes appear as hypointense lesions. T2 flare. Okay, these are acute and chronic lesions, and the hyperintense lesions are also visible. Hyperintense lesions are arranged perpendicular to the line of the ventricle. Okay, these are the hyperintense lesions, and these are known as the Dawson's fingers. This is the T1 and this is the T2 flare, or the Dawson's fingers, and this is the black hole sign. Okay, after this MRI of the brain, we have the gadolinium enhancement. Now, what is this gadolinium enhancement? It differentiates between acute and chronic lesions in the brain, hyperintense and hyperintense lesions. In the acute lesions, in gadolinium enhancement, they will appear as contrast enhancement will be present. In case of chronic lesions, no contrast enhancement is there. Okay, so in acute lesions, contrast enhancement is present, and in chronic lesions, no contrast enhancement is there. Evoked potentials. Now, what are the evoked potentials? Now, how to remember whether contrast lesions are present in acute or chronic lesions? Since in chronic lesions, C is present, it will the presence of contrast will go inversely, will follow a law of, I don't know what I'm saying, will follow an inverse law. Chronic lesions, there will be no contrast because the C is present at front. In acute lesions, contrast enhancement will be there since there is no C in the front. Evoked potentials, they are useful when suspecting brainstem involvement. Evoked potentials. Okay, first of all, we did MRI of the brain, we saw these lesions, and in order to enhance and differentiate between these lesions, gadolinium enhancement is used. Now, further we have evoked potentials. They are useful when suspecting brainstem involvement. After that, we have CSF analysis. In CSF analysis, there is increased IgG. There is increased IgG index, that is IgG over CSF protein. It is the index. Since IgG will be increased, IgG index will also be increased. And coming to cell count, it is normal over less than 50. Normal or less than 50. In CSF proteins, just remember that IgG will be increased in CSF. That's more than enough. Cell count may be normal or less than 50. CSF proteins, they can be normal or minimally increased. After that, we have the AC dissociation, which is also seen in GBS Guillain-Barré syndrome. AC dissociation is also there. Now, what is AC dissociation? It is albuminocytologic dissociation. Okay, now what does this mean? What is the meaning of AC dissociation? With AC dissociation, you will be able to remember these two points. It is the albuminocytologic dissociation. Now, there is dissociation between albumin component and cytological, which means cell component. Albumin being a protein, okay, it is increased, whereas the cell count remains normal. AC dissociation means this. It is also seen in Guillain-Barré syndrome. Now, coming to protein electrophoresis. Proceeding all these 3 points can be done on agarose gel and oligoclonal bands. Which are also seen in Lyme disease. They can also be seen here. Okay. Now, the image of oligoclonal bands is this over here. Okay. What happens over here is, due to increased IgG, there are IgG oligoclonal bands in multiple sclerosis. Okay. See, this is a normal IgG uniform band which is normally present. Other protein bonds are normal. IgG is increased. Okay. studied brain, MRI of the brain, CSF analysis. Just remember IgG, then all the points, and AC dissociation, all the points. They will come to the mind naturally. And then here, spinal cord involvement in multiple sclerosis. In spinal cord involvement in multiple sclerosis, there is eccentric demyelination. Okay, eccentric means which can happen anywhere. Okay, eccentric demyelination, and the lesions, they extend for or less than 3 vertebral segments. We already studied it over here. And also we studied earlier that most commonly it affects the cervical segments. Okay. Spinal cord involvement in multiple sclerosis, eccentric demyelination is seen, and lesion extends for less than 3 vertebral segments. Most commonly it affects the cervical segments only. Now, this is the image of the involvement of the spinal cord. Okay, we can see that mainly the cervical segments are involved. Less than 3 cervical segments are involved, and eccentric demyelination, which can happen anywhere. 3 vertebral segments are involved. Okay, and the most commonly it affects the cervical segments. This is the area of demyelination, and this was agarose gel CSF protein electrophoresis. After this, what is the diagnostic criteria? According to 2017 revision of McDonald's criteria, it is seen in multiple sclerosis. 2017 revision of McDonald's criteria. In this, clinical or objective evidence of demyelination proven by at least 2 or more episodes of demyelination disseminated in space and time. And the events, they should be separated by more than 1 month. Okay, according to the 2017 revision of McDonald's criteria, clinical or objective evidence of demyelination should be proven. Okay, clinical, which means that we have seen the evidence clinically, or any objective evidence. It should be proven by at least 2 or more episodes of demyelination disseminated in space and time. Events should be separated by more than 1 month. Okay, there must be 2 events of demyelination, okay, which must be separated by more than 1 month in the diagnosis. Okay, so now coming to the spinal cord involvement in multiple sclerosis, there is eccentric demyelination in this case, and lesion extends for for less than 3 vertebral segments. Most commonly it affects the cervical segments. Diagnostic criteria, according to the 2017 revision of the McDonald's criteria, clinical or objective evidence of demyelination proven by at least 2 or more episodes of demyelination disseminated in space and time. Now, what is the meaning of this? Clinical means the evidence of demyelination can be made by the symptoms and signs of the patient. Okay. Clinical evidence of demyelination, such as cerebral symptoms, ataxia, nystagmus, palsy, pain, and all that we have studied earlier, and objective evidence, such as by MRIs, CSF analysis, like that, of demyelination. Clinical or objective evidence of demyelination proven by at least there can be 2 or more episodes of demyelination. Okay, there can be 2 or more than 2 episodes of demyelination, by which can be clinical signs and symptoms, or MRI, CSF analysis, which has disseminated. Okay, which is spread both in space, that is it has spread in brain or spinal cord, and time, it means that the episodes, they are recurring. That is, space means spread over here, spread in brain, spinal cord, or any site related to it, and time means it can be recurring, and events, they should be separated by more than 1 month. This is also criteria, diagnostic criteria. After this, now coming to the types of multiple sclerosis. Now, what are the types of multiple sclerosis in this? The multiple sclerosis is categorized. The multiple sclerosis is categorized based on the behavior of the disease. Okay, multiple sclerosis is categorized based on the disease behavior. Now, so it can be just a second. So it can be relapsing and remitting multiple sclerosis. After that, relapsing and remitting multiple sclerosis. Then primary progressive multiple sclerosis and secondary progressive multiple sclerosis. In relapsing and remitting multiple sclerosis, this is the graph in which this is disability plotted against the time. In this, as we can see, that with disability it is relapsing and remitting. And okay, now what is the meaning of relapsing? In relapsing, it means that the disease comes in attacks, okay, in which there are new symptoms or old ones worsen. Okay, attacks होते हैं in which the new symptoms they show up or the old ones worsen, and in remitting the symptoms partially, so symptoms may partially improve. Okay, relapsing and remitting type of multiple sclerosis. Relapsing means the attacks they can occur again, and remitting means that the attacks may also partially improve. Okay, this is the case of remitting. Okay, after this, it is the most common type of multiple sclerosis. Remitting multiple sclerosis has a chance of 85 to 90%, and it has a good prognosis. Now next, coming to primary progressive multiple sclerosis. In this is disability plotted against the time axis. This is the graph in this case. Okay, in this case, now what is the meaning of primary progressive? It is another main type of multiple sclerosis. It means the disease, the multiple sclerosis, it worsens. Progressive means it worsens from the starting. Primary progressive, it gradually worsens over time from the beginning of the illness or from the primary stage. It is the second most common type of multiple sclerosis, and it has poor prognosis. Okay, secondary progressive. Again, secondary progressive. It means now what is the meaning of secondary over here? It means it comes after an initial relapsing remitting phase. In this, it is secondary to an initial relapsing remitting phase. Progressive means it worsens over time. Okay, now how is its graph? First graph will be of relapsing and remitting type of multiple sclerosis, and then it progressively worsens. And this is the least common variant of multiple sclerosis. It is the least common variant of multiple sclerosis. The most common was relapsing and remitting. The second most common was primary progressive, and the least was secondary progressive. Note. Now there is a special note below, in which the Kurtz's expanded disability status score is there. Now it is Kurtz's expanded disability status score. Disability status score, which has been given in Kurtz's expanded disability status score. Now what is it? It is a scale used to assess the disability in multiple sclerosis. So now we discuss types of multiple sclerosis, diagnostic criteria, spinal cord involvement, CSF and MRI. Now management of multiple sclerosis. The last topic in demyelinating disorders. First of all, in acute attack, the drug of choice for acute attack is high dose methyl prednisolone case of acute attack. And 500 to 1000 mg IV per day is to be given for 3 to 5 days. IVIG, intravenous immunoglobulin or plasma exchange, can be given or can be left out. In case of acute attack of multiple sclerosis, the drug of choice is high dose with hypertension 500 to 1000 mg IV per day. 500 to 1000 mg IV per day for 3 to 5 days, followed by, may not be followed by intravenous immunoglobulin or plasma exchange. This was the primary, acute attack. Now coming to the secondary prevention. In secondary prevention we have DMA, that is disease modifying agents are going to be there. Disease modifying agents. And in case of symptomatic treatment, there is going to be for spasticity, benzodiazepines, muscle relaxants such as Demyelinating. Okay. For secondary prevention, DMA, disease modifying agent, symptomatic treatment, spasticity such as benzodiazepines and muscle relaxants. Okay, in symptomatic treatment, spasticity we have benzodiazepines, muscle relaxants such as Demyelinating. And for weakness, we have rehabilitation and potassium blockers such as 4-aminopyridine, delphampyridine. Okay. And for symptomatic treatment of spasticity, we have benzodiazepine and muscle relaxants such as Demyelinating. And for weakness, we have rehabilitation potassium blockers such as 4-aminopyridine and delphampyridine. Now these potassium blockers in weakness are useful in improving walking in patients with multiple sclerosis as a prevent weakness, and potassium blockers can cause seizures. And for fatigue or sleepiness, we have modafinil. First of all, for spasticity, in symptomatic treatment we give benzodiazepines and muscle relaxants such as Demyelinating. For weakness, we give rehabilitation and potassium blockers such as 4-aminopyridine and delphampyridine. Potassium blockers are useful in improving walking in patients with multiple sclerosis. Potassium blockers can cause seizures and fatigue or sleepiness in case of modafinil. Spasticity, weakness and fatigue or sleepiness. Now disease modifying agents. Coming to disease modifying agents in secondary prevention. What are they? First of all, we have alpha-4-B1 integrin inhibitor. Alpha-4-B1 integrin inhibitor, in which we have nitalimab. Alpha-4-B1 integrin inhibitor. But there is a problem. We need to check the status of the JC virus before administering nitalimab. We have to check the status of the JC virus before administering nitalimab. Nitalimab enhances the risk of PML, progressive multifocal leukoencephalopathy, in patients with JC virus. Okay, nitalimab enhances the risk of PML, progressive multifocal leukoencephalopathy in patients with JC virus. Nitalimab in multiple sclerosis. It worsens the neuromyelitis optica. Even though it is an alpha-4-B1 integrin inhibitor which is administered in the management of multiple sclerosis, we should check the status of JC virus before administering. The other adverse effects are: it enhances the risk of progressive multifocal leukoencephalopathy in patients with JC virus, and it worsens neuromyelitis optica. Okay. After that, we should know that it is the first line medication, but to check the status of JC virus. Now, anti-CD20 monoclonal antibodies. Anti-CD20 monoclonal antibodies. What are they? Till now, in DMAs, we have studied alpha-4-B1 integrin inhibitors, and now anti-CD20 monoclonal antibodies, we have ofatumumab, and more importantly, ocrelizumab. Ofatumumab, and ocrelizumab. It is again the first line medication. Now, ocrelizumab is the first monoclonal antibody and the first FDA approved treatment for PPMS. First FDA approved primary progressive multiple sclerosis. Okay, ocrelizumab is given in primary progressive multiple sclerosis. After that, S1P receptor modulators. In this we have, just remember the suffix mode. Then remember fingal, just like the word finger. Remember fingal, Sipon, or Zan. Fingal, Sipon, or Zan. Okay, Siponimod is the most studied drug for SPM. Okay, now Siponimod is the most studied drug. Ocrelizumab was the most used drug for PPMS. Now, most studied one for the second one is for secondary progressive multiple sclerosis is Siponimod. Okay. After this we have DMF, that is dimethyl fumarate. Then the fifth one is glatiramar acetate. First for dimethyl fumarate, then glatiramar acetate. Now some other drugs are interferon beta 1 and mitoxantron. Now what are these rare variants? Just a short note on the rare variants of multiple sclerosis. Till now we had studied limiting and progressive type of multiple sclerosis, primary progressive multiple sclerosis, secondary progressive multiple sclerosis. After this we have acute MS or Marburg variant. Okay, Marburg variant or acute multiple sclerosis. It is a fulminant form of multiple sclerosis and it has the worst prognosis, even after the secondary progressive multiple sclerosis. And in this case, death occurs in less than 1 to 2 years of the okay. So in this case, where we death occurs in less than 1 to 2 years of onset of multiple sclerosis or of this disease, and it may be associated with tumor-affected lesions, okay. They are just circular lesions in the brain, okay. But they are not concentric, okay. These lesions are not concentric, they are just like whitish shadows. Acute multiple sclerosis or Marburg variant, it is fulminant, it has worst prognosis, that may occur in less than 1 to 2 years of onset of disease, and it may be associated with tumor-affected lesions. After this, there is concentric sclerosis of Ballo. Okay, in this is again a fulminant form of multiple sclerosis. It again has poor prognosis, but not the worst one. And there are areas of demyelination alternating with areas of remyelination in this case, which leads to a concentric which leads to these kind of concentric, okay. Oh, I can see heart over here. This can lead to these kind of concentric alternating areas of demyelination known as concentric sclerosis of Ballo. That's all in the management and diagnosis of multiple sclerosis. Just a quick review of management of multiple sclerosis for acute attacks, secondary prevention, symptomatic treatment, and then the rare variants of multiple sclerosis. That's all.